Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Supreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Joining us today is Dr. Nikita Shah, who is a renowned psychiatrist based in Mumbai, India, specializing in adult psychiatry with a particular focus on women's health, depression, and anxiety. With years of experience, she is dedicated to addressing the complex interplay of biological, psychological, and social factors that contribute to mental health and mental health disorders. Dr. Shah takes a comprehensive approach to care, combining evidence-based medication with psychotherapy to help her patients regain balance and thrive. So, welcome to this episode of the MenopauseWize podcast, Dr. Shah. This is a special episode on depression and sadness at perimenopause and menopause. So, thank you so much for joining us today.
Thank you so much, Dr. Sapir. It is so good to speak to you about these topics because I think they're so important for the menopause transition.
Right. Thank you. It's the slogan that mental health is health. I think it's becoming more evident and more clear to people, but at the
Yeah,
same time, we
yeah,
have a lot of work to do with regards to mental health.
absolutely.
Um, yeah, so mental health is so central to our well-being and still so poorly understood, especially at perimenopause and menopause, where these symptoms actually come into our faces, right? Because suddenly we see women going through this transition and having these symptoms, and most of them are quite unaware that it's linked to their hormones. So it's such an important topic to discuss because if they're not feeling
Absolutely.
well, then they're not doing everything else.
Yeah,
Let's start with the basic um, sort of definition or way to differentiate between sadness and depression. How does one figure out, oh, I'm just sad, or am I really depressed and I need help?
right. So this becomes very important, especially at the time of the menopause transition, because we do have certain mood symptoms that, as it is, happen as a result of the hormonal changes during the menopause transition. So, and what happens with mood disorders is that because they are in a spectrum with your normal moods, like normal mood and your reaction, it becomes difficult to tell when it is just a symptom and when it crosses over to disorder. So what happens is that during the menopause transition, in the early perimenopause and the late perimenopause, we do see certain what we call depressive symptoms. So this could be irritability, mood swings, brain fog, certain amounts of anxiety, right? Some people say it's just crankiness, getting teary-eyed very easily, right? But this is called, it crosses over to clinical depression when it fulfills the diagnostic criteria for what we call depression. Now, depression is different from garden variety sadness in its pervasiveness, its persistence, right? And the way it leaks into your everyday experience. So, this is basically defined as at least 2 weeks of mood changes, which is feeling sad almost all the time, and also sometimes not being able to enjoy previously pleasurable activities. So, things that you used to like before either don't give you as much pleasure, right? Or you don't feel like doing them anymore. And then it has certain cognitive changes. So, one of the hallmarks that we see in depression that we may not see in just sadness or mood changes is this symptom of worthlessness or guilt. right? There's a huge amount of worthlessness that comes in at that time, and it almost seems unshakable when it's actually depression, right? And along with that, there's some amount of pessimism, which may then over time go into recurring thoughts of death. It could also be things like difficulty concentrating, attention and concentration is lost. There's also certain biological changes. So we call them vegetative changes. So you'd see changes in sleep, you'd see changes in energy, and you'd also see changes in weight. Now, you realize how this is so linked with the menopause transition. But in depression, we define weight changes as a change of about 5% body weight in about a month. So it's quite drastic. So what we're seeing is that it is falling outside the normal spectrum of mood changes, and that's when we call it depression rather than depressive symptoms.
Mm.
Like
So you
that.
you you said it needs a certain criteria. Are these criteria kind of listed in
Absolutely.
something?
So
Mm.
we have two kind of criteria. So these are the criteria for depression based on the ICD-11, which is the International Classification of Diseases,
Mhm.
which is put out by WHO. And there's also a similar classification given by the DSM, which is an American system of classification.
Right.
So both of them are fairly similar, and
Mm.
both of them do find that this could sometimes be outside, things like just grief
Mm.
or what would be considered natural in its pervasiveness, persistence, and its
Mm.
disproportionateness. Yeah.
Mm. I think that's the important thing. It's sometimes you hear the term depressed so loosely used, like, oh my God, I'm so
Yes.
depressed.
Yeah.
It's but
Yeah.
do you really? Yeah, it's probably a term that we should take a
I'm
little more
sad or
seriously. Yeah,
yeah,
yeah.
yeah,
Plus, also, I feel like things like, oh, my cholesterol's high. It's like this quantitative test that's going to give you something,
yes,
and it's such a relief to know that there is a checkbox that you need to tick off to actually
absolutely.
say whether someone is
Yes.
depressed. Because, yeah, yeah.
Yes, and that's the other problem with when we use the word depression is that we see it as a monolith, but
Mm,
actually we have grades to depression. So it could be
mm,
mild, moderate, and severe,
mm,
depending on how many of these criteria are being fulfilled and the
mm,
severity of it. So
mm.
even within depression, it's not just one entity. So
Right.
that's also important to note. Yes.
Right, right. So
Yeah.
it kind of makes me feel relieved. I don't know about our listeners, but it makes me feel relieved that if I go to a specialist, the person's going to have to not just make a judgment on how I'm feeling.
Yeah.
It's not going to be just a subjective judgment that no, no, she doesn't sound depressed or she
Yeah.
sounds depressed. Like I don't have to convince the person. The
Yeah.
person is going to actually objectively see whether I'm depressed or not, and then classify me. So
Absolutely.
that's
Absolutely.
that
Yeah.
that's that's
Yeah.
that's wonderful to hear.
Yes.
Um, you mentioned lack of joy, and I feel like so. Is it called anhedonia?
It's called
Uh,
anhedonia. Yes, it's called
and
anhedonia. That's
yeah.
just not feeling pleasure anymore.
Mm,
And
mm,
actually, that is one thing that makes depression so much worse than sadness because the ability to perceive pleasure may
mm,
at least make you do activities that make you feel better. But when
mm,
you lose
mm.
that, you're just like, okay, but nothing is making me feel better. So what
Yeah.
what can I do? You
What's the
know?
point? Especially like things
Yeah,
like exercise, like you know that
absolutely.
the run can
Yeah,
make you feel better, but you're
yeah.
not moving because it's like
Because
it doesn't do anything
it's
for
not
me.
doing anything for
Yeah.
you anymore.
Yeah,
Yes.
yeah,
Yeah.
yeah. That
Yeah.
is so interesting. Um, why do you think these mood changes happen at perimenopause and menopause? What does research really say
Right.
to us?
So what happens is during menopause, as you have explained to the people who listen to your podcast regularly, there's a cascading changes in the female sex hormones. So these include estrogen, progesterone, and testosterone, right? Including the other ones that are secreted by the brain. Now, the limited understanding that we have when we study this in bio, right, is that it affects your reproductive system. But these are actually neurosteroids. So they affect the neurotransmitters of your brain, and it modulates the chemicals in your brain that influence mood and cognition. So most people have heard about serotonin, dopamine, norepinephrine. These are very, very important to maintain your mood. And along with that, there are some other chemicals like GABA, which is a brain inhibitor system, which is very important for your anxiety modulation, right? In addition to that, estrogen has been very important to even modulate your synapses and circuits. And they also give a very neuroprotective effect to the brain. Now, another change that, of course, we know over the last several decades is that unlike what we thought earlier, that the brain is incapable of producing new neurons or repairing itself, we do know that the adult brain has certain sections that do produce new neurons. And what happens in things in depression is that you lose the ability to regenerate as well. So estrogen does give you this neuroprotective effect. Along with that, progesterone is also important for GABA. And we also know that testosterone is also extremely important. In fact, the reduction of testosterone is linked to the loss of libido in both sexes, including women. So and it's not that it's going down at a slow, like predictable rate, right? So it's almost like a roller coaster. And
Yeah, yeah, yeah.
yeah. So and in fact, because it's like this unpredictable, like slow, but like not regularly down, a lot of these symptoms kind of creep up on you insidiously.
Mm,
And
mm,
that actually may prevent you from noticing this is happening because it's happening gradually, gradually, gradually till like there's a point where it hits depression. So that's another reason why it becomes difficult. But these are the causes for it.
mm,
But there are
mm,
several risk factors also that could predict that you'd be at a higher chance of developing depression.
mm,
So the causes are largely, the loss of our hormonal modulation and also aging, because this is
mm,
proper midlife, right? And in addition to that, we have risk factors that may predispose you to having a worse time of this than,
mm, mm.
yeah,
So what are some of these predisposing factors? Let's say all of
right,
us will go through that
yeah,
slumped, and
yeah,
women with surgical menopause more acutely because their ovaries are
more
suddenly
acutely,
removed.
absolutely. Yeah,
Um,
yeah.
but how does one, what are the warning, the bells that should ring that, oh, I have this, and hence I will be more predisposed to depression at menopause?
Right. So if you've ever had, so there are certain, like let's say, let's put that in biological or health risk factors. So if you've ever had a depressive episode before in your life, you're more likely to develop depression in this transition. Also, if you've had very severe PMS, right, premenstrual syndrome or a PMDD. Also, if you've had postnatal depression, you're at a higher risk of developing depression during the transition. Along with that, if you have any concomitant or comorbid medical condition, right, that could also make you more predisposed. So you could think about like hypothyroidism, certain, you know, like let's say autoimmune disorders,
Mm,
that could make you likely to develop depression. Also, if you have higher BMI, you're more
mm.
likely to depression. So these
Really?
are certain biological risk factors, and then along with that, we have certain psychological, like I know there's still like this artificial divide between biological and psychological, although it's all, as we
One
say,
year.
like it's all in your head. Actually, it's all the chemicals are also in your head. But like just an artificial divide is psychological. Like if you have certain personality traits where you tend to like ruminate more, tend to be more anxious at baseline, that could
Mm,
predispose you to that. And actually, this midlife transition is interesting because you have um, certain life changes that usually happen at midlife. So
mm,
like let's say there's a change in role. So if you're working, You could be entering like upper management, middle management, or, so your stressors kind of increase at that time. Along with that, unfortunately, women still bear the heavier burden of managing, interpersonal relationships and roles in the household. So it could be like looking after children, changes in your children's, so like let's say a lot of children are of college going age at that time.
Yeah.
So they might move out or they might not need you as much. So there's a change in role there. There's also certain interpersonal within, like if you're married or in relationships, even your partner may be likely to hit midlife at that point of time. So there's that also happening, the additional stress of that. And also with aging parents, you could have ailing parents, you could have, death of parents. So there are significant life changes that happen at this age, which kind of predispose to it. So if you have a severe life event or certain daily hassles that you're dealing with, it
Mm,
predisposes you to depression. And then there are also certain social factors like low social support. You could have, if you're unable to work outside the house, it could predispose to depression. There are certain demographic factors, like if you're from a lower socioeconomic kind of
okay.
strata, or you have financial difficulties at this age, you're more likely to be exposed to developing depression. So these are all, you could call them triggers or risks, which
Mm,
one should uh, keep in mind when you're kind
right.
of just being like, is this normal, or am I feeling an accelerated change? And these could be
Mm.
certain that should make you
Yeah,
think about it.
and these are like so difficult to separate out from what's going on biologically, right? Because
Yeah.
almost every woman will be going through all of these changes. Some all, and some of them, just few of them. But that
Yes.
interplay of daily drama with your hormones and the
Yes.
inability of self to understand it. Forget the outsider, by
Yes.
outsider, I mean
Yeah.
people at work, people at home, your children, like what's going
Yeah.
on with this woman? Why is she
Yeah.
behaving so oddly? Like,
Yeah.
why did she make,
Absolutely.
why was my tiffin packed this morning? She just didn't wake up today.
Yeah.
So it's so hard
Yeah.
to differentiate, and it's so
And you can
fascinating.
almost see how guilt can slowly creep into
Yeah,
this,
yeah,
just
yeah,
not being able to function the way you would like to,
yeah, yeah.
So those are things that really it becomes very interesting. But I think over time, like if you feel
Mm,
that, okay, I feel that I'm not being able to cope,
mm,
I think if you go to a healthcare professional, they would be able to parse it apart, like just from experience, whether this is
mm.
the depressive symptoms or we're looking at a depression.
So
Yes.
the important thing is getting help when if you think you need it, or sometimes you don't think you need it,
Exactly.
and maybe it's good to get it
Yes.
across a
Yes.
professional.
Yes.
Yeah, yeah, yeah,
Yes.
yeah. What do you think? You explained to us about how hormones change and impact our emotions. How can we like simple daily habits and lifestyle as a first step for someone who's going through, I'm not saying like clinical depression and is just not being able to move,
Yes.
but let's say I am like, let's say I'm going through some sadness, which I feel is quite severe, and it could get into depression, and I can see myself sinking down. What is it that
Yes.
I can do to prevent myself to make my mood a little better, less sad, or not
Right.
get depressed? Yeah.
Okay. So, so this is very important. This falls under what we call positive psychiatry. So
Hmm.
this is how do you do preventative uh, um, lifestyle changes, right?
Mm,
So these, like the most important thing that anybody could tell you to do is one, anything that is physical exercise based. And although that sounds like such a simple thing, but just getting out of doors, getting into nature, exercising, it doesn't have to be anything extremely hectic if you're feeling, because fatigue is a very important, it's very common, symptom of
mm,
depressive symptoms menopause. So even if you give yourself permission, like the number of my clients that are unable to exercise because they hold such unrealistic standards of what exercise looks like,
mm,
and
mm.
beat them up about not being able to exercise. So
Yeah.
even if you can just start with like a small walk, like 20 minutes, even 3 times a week, 4 times a week is
Mm,
helpful. And of course, a really, really good thing is a combination of just like exercise, low impact cardio with some strength training,
mm.
so that be careful about your BMI, your weight, things like that,
Yeah.
right? But several studies that have been done to show that a lot of different kinds of exercises help with depression and menopausal symptoms. So this could be something as simple as a walk, could be strength training. A lot of mindfulness based exercises are also very, very helpful, right? So, one of the risk factors that I missed telling you earlier is that vasomotor symptoms, so your hot flushes, especially if they disrupt your sleep. So, nocturnal hot flushes are very, very linked to the development of depression,
Mm,
right? So things like any mindfulness based exercise, so yoga, things like that, even if they might not help you with depression, they do help with these symptoms.
mm,
So that would help
mm,
you prevent depression. So it has been found that mindfulness based exercises would help you with sleep, would help you with your vasomotor symptoms. So those are interesting lifestyle changes to put in. There was also an interesting study out of China which said that your diet can influence the development of depressive symptoms. So if you're eating high glycemic index foods, like in China, of course, was like noodles, dim sum, things like
rice.
that,
Yeah.
you're
Yeah.
more likely to develop depression. It was actually linked to depression itself. And if you're eating whole foods, legumes, higher proteins, you're reducing your risk of developing depression, right?
Wow.
So dietary changes are also very important. And a very, very important lifestyle change is to develop social supports. And this is
Mm,
very important for women because in my practice, I've found female friendships to be extremely interesting because they're very linked to your life phase. Again,
mm,
because of kind of lopsided burden that women have to carry for household work. So what
yeah.
happens is a lot of it, one tends to lose a lot of the ability to socialize with friends if you're in a very, like, let's say when you're in the childbearing age, or if you're very, very deeply involved with your career, along with looking after children and the household.
Mm,
So it's very important at the time to seek social support. So whether it is like simply just going out, meeting your friends, or even joining certain groups that would allow you to discuss or kind of understand that you're not the only one who's going
mm,
through
mm.
these changes. That's also social support is a huge protective factor for the
Mm.
development
Yeah.
of depression. So this is like a very, very simple change that one could do. And
Mm,
also, additionally, there have been lots of studies that have been done in understanding how your attitude towards menopause
mm,
could affect
mm,
the ability to kind of prevent depression. So there's been
mm,
a lot of, I think, media-wise and self-imposed standards-wise, a kind of negativity towards aging and menopause. So being able to, in a way, normalize it and understanding the freedom that comes
mm.
with menopause. You've really spoken about this quite a bit, but I think there are studies that also go to prove this. So being able to understand what all freedoms you've developed because of this phase shift in your life would allow you to perhaps um, kind of tolerate the frustration that's coming out of these changes a little bit better. So
Yeah.
these are some simple lifestyle modifications that I could recommend.
Well, that's a lot of useful information. The question I have is, it's about which I face all the time is implementation failure. That you know the exercise is going to help you, and you know that the change in diet is going to help you, but you're unable to implement it. It's
Yes.
okay for someone who we see this even in people who are or women who are not sad or depressed.
Yes.
They know it, but they still will eat that muffin or whatever else. Now, someone
Yes.
who is depressed,
Y-
how does
Yes.
it's a chicken egg problem. I know this
Yes.
is going to help me, but I'm unable to pick myself up to go for a walk. What do I do?
Absolutely.
Yeah.
Right. So when one is depressed, of course, this becomes a bigger, bigger problem to solve.
Mm,
And at
mm,
that point of time, we might actually not just recommend mindfulness to start exercising, but mindfulness basically. So this would then, like, if you would do any of the psychotherapies that are helpful for
mm,
this, what we would do is we would break down antecedent triggers to preventing that are preventing one from kind of doing a pro health activity, right? So
mm,
one of the things mentioned to you is sometimes having unrealistic standards for if I can't do that kind of exercise, I'm not gonna do anything.
right.
Oh, whoops, I ate one thing wrong today. Now I'm just gonna go like, oh, I'll start on Monday.
Yeah.
Those kind of those
Yeah.
kind of thoughts.
Yeah.
So one of the things that I really, really recommend is like coming up with a goal, but then slowly
Mm,
working towards it. Because this is
mm,
not a habit to cause like a quick change. This has to be a habit that you're going to have to sustain almost for the rest of your life because these are all good habits
yeah.
anyways.
Yeah.
So being able to for different kinds of personality types, of course we would approach this differently,
Mm,
but sometimes kind of being kinder to yourself and kind of like nudging yourself and being like, can I just start with one of the things that I really recommend to clients is like, let's say that if your goal is in a month, you want to do three, like let's say at the end of the month, you
mm,
want to hit going for a walk 4 times a week for
mm,
half an hour each,
mm,
right? What I would say is that so that you don't go into what we call the all or nothing dilemma, you'd
mm,
be like, hey, in the first week, can I just start with 2 days minimum, three
yeah.
days max? Don't overdo it because then you'll have a
Right.
reason to not go,
Mm,
you
yeah.
know? So don't overdo it and just go for like minimum 15 minutes,
Yeah.
maximum 20 minutes, and work up to what you want to do. And keep the goal doable so that even if it's like Thursday and you haven't even gone for a single walk, you can still like get out on Friday, still get out on Saturday, and still get your weekly quota met. And that tick mark actually really gives you that sense of, okay,
Yeah.
I
Yeah.
got a handle
I
on
did
this.
something.
So
I did something.
yeah,
Yeah.
and so many of us have such a difficult voice in your like,
Mm,
especially because when mood and guilt comes in, like, oh my God, you're not doing anything. This is common sense. You used to exercise. You're not doing
yeah.
anything anymore. Instead of that negative chatter, because at some point in your life, that negative chatter may have propelled you
Mm,
to do things.
mm,
But at
mm.
this time, because your body is not cooperating, your mood is not cooperating, it's better to be like the gentle parent at that time and be like, hey, this is my goal. Let me work up to it.
Yeah.
So
Yeah.
that kind of thing.
Yeah.
Yeah.
No, 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 that's really useful information.
Yeah.
It's that people underestimate the power of 5 minutes a day and what it
Yes.
can do when it compounds 5 minutes every day.
Yes.
So yeah, starting
And
small is such a
yeah.
beautiful thing.
Yes,
Yeah.
and I think once you start doing it, that's when you realize, okay, especially if you're not depressed, you'd be like, oh my God, even if I can just like mindfully look at the trees, or like, I mean, if you're in India and it's hot, you've gone early in the morning, even in summer, like you have beautiful flowers
Yeah.
blooming. So there's always something to kind of anchor,
Yeah.
feel some sense of joy and kind of let that propel you onwards. In fact, even for food, I feel like once people start making changes towards healthier food and they're practicing some kind of mindfulness,
Mm,
when they eat that muffin, feeling guilty about the muffin, if they're just thinking about like, okay, how is that making me feel like after I eat it?
mm,
You know,
mm.
when like I think like when you eat like a junk thing like a vada pav and then you just
Yeah.
feel it like sitting in your
Sitting in your
stomach, you feel
stomach,
like
like,
okay,
oh my God. Yeah.
yeah, like that doesn't feel so good, and I feel good when I'm eating the healthier food. You know,
Yeah.
same for alcohol. Actually, I didn't mention alcohol at all, but alcohol is
Mm.
one of the really, it worsens your vasomotor symptoms. It affects your BMI. It can really worsen your mood symptoms. So, in
And
fact, a lot of my
your
clients
sleep.
will, your sleep,
Yeah.
absolutely. It kind of disrupts your sleep architecture completely
Yeah.
because you might feel like it helps you fall asleep, but it doesn't help you get deep restorative sleep.
Mm.
So a lot of clients will say, Nikita, from the time I didn't drink for so long, and then I
Mm.
drank and I was feeling so miserable the next morning. So actually,
Mm.
those mind practices help you stay on track then.
Mm.
So starting
Mm.
with a small goal and then noticing the difference and letting that be
Yeah.
the catalyst to continue and improve that behavior.
Yeah.
Yeah, that is
Wonderful.
what I would
And like
recommend.
food is just so obviously linked to mood, and we still don't connect it, considering sugars hidden or not, like even like
Yes.
refined flour, that maida is going to
Yeah.
create that fluctuation in your blood glucose, go high, go low. And we know that proteins will provide us with amino acids, and
Yeah.
serotonin, as you mentioned
Yeah.
earlier, is
And
also
you're
requires.
less likely, like if you're feeling more satiated, you're less likely to binge, less likely to feel worse. So
Mm.
a lot of it kind of straightens out on its own. But being kind, working up to it, and being mindful about the changes is what's usually helpful.
Yeah, yeah.
Yes.
So true, so true. Okay, so let's come to let's say I've tried all my lifestyle changes, I've done everything, I've got social support. I'm still not feeling it. I'm not being able to get out of bed. I've kind of come under the depressed category with one of your classifications.
Right.
And what would be the next step in terms of pharmaceuticals?
Okay. So what we normally recommend is that depending on the severity of the depression. So if it's mild depression, we could still try between lifestyle modification, psychotherapy, exercise, and what we've discussed so far, right? And we'll speak about psychotherapy in a while. But if it is moderate and severe, you might be unable, as we discussed, to do these changes.
Mm,
So been found based on literature is because the causative factor in this is the hormonal
mm,
changes. What we
mm,
have found is that, of course, hormonal therapy, whether it's estrogen therapy or hormonal therapy, is extremely useful. In fact, for a lot of my clients who do psychotherapy with me,
mm.
and I'm not able to prescribe because they don't stay in the same country, they have just gone to their gynec and got hormonal therapy prescribed, and they barely need to
Mm,
see me anymore. They're
mm,
just like, okay, I'm
mm,
back, I'm thriving. So hormonal therapy is extremely helpful,
mm,
especially for depression and the menopausal transition, because it is the one thing which will not only help with the other symptoms and the other changes that you're going through, but also
mm,
help the most with depression. So I would normally recommend that as the first option if there is no contraindication to it and if it is available to the individual who's going through this. Um, of course, if there are certain contraindications,
of course.
then we would. And of course, what we have found is that there is a hesitation for a lot of people to start hormonal therapy,
Mm,
whether it's not easily available where they are.
mm,
And at that point, I would recommend antidepressants. Now, there are robust studies that do talk about antidepressants that are helpful. I've also found it in clinical practice. So there are several classes of
mm,
antidepressants, but the ones that have been recommended fall under what we call SSRIs,
mm.
NIs. Okay, SSRIs are what we call selective serotonergic reuptake inhibitor. Okay,
Wow.
and yeah, it's a mouthful,
Yeah,
which is why I always give you
yeah, yeah.
and some of the common medicines in that we have seen being used in depression in the menopausal transition is paroxetine
Mm,
and escitalopram or
mm,
citalopram. These have been commonly used. Now, this sounds really complicated, but would you want me to explain a little bit how these work?
I think it
Or
would be useful because drugs like paroxetine are also the US FDA approved
yes,
for use as
yes,
hot
yes.
flash treatment, and so basically kills
Absolutely,
two
because
birds
it's
with
one
one
of the
stone. Yeah.
few SSRIs that don't increase anxiety when you start it. So which is
Oh,
why it's
really?
very, very helpful. It's very helpful for that reason. So what SSRIs do is we have, uh, so to explain what serotonin
Right.
is, it's a neurotransmitter.
Mm,
And a neurotransmitter is kind of a chemical that's packaged at the end of your neuron. So, neuron is your basic nerve cell that helps one neuron communicate with the other neuron,
mm,
right? What happens in depression or the menopausal transition is that our brain produces less serotonin,
mm,
okay, along with other chemicals. So, less dopamine, that's what causes anhedonia, less norepinephrine, it causes reduced initiation, right? So
mm,
all the neurotransmitters are kind of depleted, and our brain actually only likes to be efficient. So if the neurotransmitter is reduced, it starts knocking out the receptors. So how I explain this is we're looking at a desert. So there's no rain and there's no growth, there's no vegetation.
mm,
So these are very expensive molecules for your brain to make. So
mm,
it doesn't get destroyed in the space between the two neurons as soon as you use it. Unlike certain other neurotransmitters, it gets pumped back
mm,
and it gets reused, right? So what these medicines do is it blocks the pump. Hence, it's called a reuptake inhibitor, right?
mm,
And what happens is it kind of just floods that space now with serotonin. And it's
mm,
kind of like kind of catching your ear this way. So now that there's more serotonin in the space, your brain's like, okay, let me make more receptors. And now that there's more receptors, they're like, oh, let me make more
right.
serotonin. So kind of, and which is why, there's like this misunderstanding that these are addictive molecules. No, like an antibiotic, it has to be taken for a certain length of time for this whole system to get corrected.
Oh.
So these medicines have to be taken for about 6 months to a year from the time you start feeling better. Actually, a year to prevent relapse, right? So that's the whole course of the medication. And that's something I always explain to people when they start it, that that's what you're committing to, right? If you feel better, you take it for a year.
And how long does it take to feel better? Of course, there'll be
Oh,
individual
yeah.
variation,
Yes,
but
psychiatry
average
is,
length.
yeah, it's a discipline of patience. So it takes about 2 weeks for people to start even noticing any
Mm,
changes.
mm,
And in a month from the time you start, you would know whether that molecule at that dose is helpful for
mm,
you, right? So what are
mm,
the changes you see? You normally see changes in the physical symptoms first. So you might feel like less, like you're crying less. You might feel like your
mm,
energy is a little bit better. Maybe the
mm,
mood is becoming a little bit more stable, right?
mm,
So you see changes in those cognitions, like, the worthlessness and the
mm,
guilt
mm,
get better. It's always going to get sad. This is my life forever, forever and ever. Those are the changes that start happening at like the 1 month mark. And hence, like at the 1.5 month mark, people are like, I think I'm all good. And they'll just like stop the medicines and the symptoms recur, which is why
mm,
we continue it for a month, because it's not a full correction yet, right? So SSRIs are selective just for serotonin, whereas SNRIs impact your serotonin and norepinephrine. So that is desvenlafaxine and venlafaxine, 50 milligrams. That has also been very helpful in the treatment of depression. So these are some of the psychiatric molecules
mm,
that
mm,
we give. There are also certain studies that say that if it's largely sleep disruption, some studies have looked at melatonin as well so that it corrects the sleep. But largely for depression, these are the two psychiatric molecules that are the most helpful.
mm. And sleep plays such a crucial role, right? In mood on its own. If you could separate out and do a
Absolutely.
study and see the number of women who don't sleep well at perimenopause and menopause,
Yes,
and just
yes,
correct their mood by correcting their sleep,
yes,
um,
absolutely. Yes, yes.
probably have less depression just because they're
Resting.
sleeping better.
Absolutely,
So
absolutely, absolutely.
yeah,
Yeah,
so that is it's really fascinating.
yes,
The whole human body and
yes,
mind and how they're working is just so beautiful.
absolutely.
Yeah,
Yes. So
and it's
these are some of the pharmacological
mm,
options that one can
mm.
opt for during depression. Yes.
So very often we hear women and gynecologists or prescribers are a little afraid of using hormone therapy, and that's a different few
The
episodes on its
conversation.
own. Yeah,
Yes,
but
yes,
having said that, it's mainly because they're afraid of it having side effects.
absolutely.
And
Yes.
prescriptions for SSRIs become easier to write, but are they also the every drug comes with its set of
With
problems.
that, yes,
Yeah.
absolutely. Yes,
So could
yes,
you describe some of the nothing is side effect free, including vitamins. So if you could tell us some
yes.
the problems that could
So
arise with this as well.
commonly, the most common acute, and this is actually the most difficult side effect to deal with, is that because your brain has had such a paucity of these chemicals for so long, when you start it and that flooding of the chemical happens, uh, people conversely have a worsening of anxiety for the first 4 or 5 days. So it seems almost counterintuitive, and actually, that is the most common side effect that we face. So it requires a lot of explanation and patience, right? That we will see a worsening for the first 4 or 5 days. Please bear with it. Maybe we start at a lower dose and build up to prevent that. That and GI side effects. So basically, acidity, some amount of, gut churning, those kind of symptoms. Those are the most common acute side effects. But of course, acute side effects are one thing, long-term side effects are another.
Mm, mm,
Most common long-term side effects of SSRIs are, the effects that it has on sexual function and libido. It may reduce libido for some clients, and for some clients, it might actually be very like you don't notice it because the menopausal transition and depression itself comes with reduced libido. So sometimes
mm,
with an improvement in mood, you might see some improvement in libido, but you
mm,
might see this happen. And so also SSRIs are a lot more cardiac friendly
mm,
than previous antidepressants. So antidepressants got a bad rep because of the older antidepressants that existed,
mm,
which used to cause certain cardiac side effects. SSRIs are extremely cardiac friendly. So that's one of the things that we work to dispel. And the other side effect is, and some people report some increase in weight on medication.
mm,
Now, this has with SSRIs, we see this very less often, which is why it's considered like a gold standard. It's so selective that it's unlikely to cause these additional side effects. So,
mm,
how uh, paroxetine is quite weight neutral. Escitalopram is quite weight neutral, which is why these are the molecules that we would prefer in
mm,
somebody who's on a change like that. So these are things that can very easily be managed, especially because these are a lot more friendly in that sense. So and also what we see is this risk benefit analysis, right?
mm,
So what I often explain to my clients is that there's a lot of risk involved in depression itself because of the cascading metabolic and aging, accelerated aging that depression causes. So if we can kind of reduce that with a molecule, then we're also getting these additional benefits where, you're not going into um, insulin intolerance, you're not going into, there have been certain clients of mine of this age group that have had to reduce their antihypertensives
Mm,
once they get on
mm,
anti, because so many of these, like if it's working as a stress modulator, you're reducing the metabolic damage that stress causes on your body. So I often like it's a very delicate
mm,
kind of risk
mm.
benefit analysis, which is why we do give a trial of stopping the medication in a year, because we don't want to give it for longer than it's helping. And for a lot of clients, like after a year, they can stay off the medicine. Yeah.
Right,
So
right.
that's one of the things we
Yeah,
look at.
I
Yeah.
think that's an important message that use the tool when you need it, and it doesn't have to be
Yeah,
forever. But
because
at least it's a
yeah,
crutch
because
to get you on the
yeah,
other side.
yeah. And even if we notice, right, like whether it's HRT or if it's antidepressants, we found them to be there's a window of opportunity where it is the most
Mm,
helpful. If you're giving it in a postmenopausal setting, they're not as helpful as they are, in the perimenopausal setting. So that is the reason why it's important to work with a healthcare professional to figure out what your risk benefit analysis for
right.
this is.
Right. And I think this whole concept of risk benefit needs to be better digested by everyone,
Yes.
because if the commonest question that I face usually with hormone therapy is it safe? And I'm like, crossing the road in Mumbai city is not safe, but we
Yes.
still do it. And
Yes,
and so
absolutely.
what is safety?
Yeah,
We are making this, how can one invest in mutual funds without reading the fine print? There is risk. So
absolutely. Yeah,
so I think
yeah,
this is a really important aspect that you brought out, is there is a risk benefit analysis, and in prescribing every drug, it's not just
everything.
hormones.
And in fact,
And
not treating it at all comes with a risk. And that's usually what I really try to explain to people is that not treating a depression, right, is as risky or worse, more
more,
risky.
yeah,
So,
yeah, yeah,
yeah,
yeah.
yeah. So that, but also what I found is one of the things that kind of hold people in good stead is, working on your coping mechanisms while you're getting your, if you're starting antidepressants, I do recommend if it is available to you, also thinking about different kinds of psychotherapy. So I find that it's difficult to talk about treatment for depression without talking about psychotherapy. We spoke about lifestyle
Yeah, yeah.
modifications, but psychotherapy, especially given mood swings and the phase changes involved, is very, very important for depression. So that is also an important treatment module.
Mm.
Yes.
Yes, I like psychotherapy, and like if you could speak a little bit about, because I think psychotherapy is at its nascent stage, especially in India,
Yes.
and there is a lot of taboo attached to it. Like according to me, everyone needs therapy, but the
Yes.
the point
Yes.
is, because it can be so insightful. But could you tell us a little bit about why people don't seek psychotherapy? In your experience, like what is the stigma, taboo attached to it?
Right. I think that one of there are several, but one of the first few ones are, why do I have to talk to somebody else when I can just talk to, my family members, where I can just talk to my friends. There was also a very interesting insight I got from an older client of mine, that everybody now just wants to make their life easier, like they don't want to like tolerate, like like this kind of epitome of, like women
Mm,
and, like our ability to suffer. I
interesting.
call it like the suffering Olympics. So so
I
we
like that
suffer
term.
so
I'm going to
much.
note it. Suffering
Yeah.
Olympics.
Right. So that becomes another reason, but also this not understanding what one is doing in therapy. Lots of people link therapy as venting, and in fact, venting does not help your mood
Mm,
state at all. Like if you're just
mm,
calling and just repeating the same thing over and over, that's not what therapy is. So first, understanding what therapy is, which is
mm,
actually understanding your patterns of
mm,
thought, understanding how
mm,
the mechanisms that you've built in your life so far, some of which are serving you, but some of them are not serving you anymore. Being
mm,
able to kind of dispute them and replace them with more suitable coping mechanisms and thought patterns to where you are in life. Like a lot of us learned how to cope with the world when our world
Mm,
was a lot, right? And our abstract thinking was nascent. So, like, it's very easy to say good, bad, you know,
mm,
uh, a good thing to do, this is a bad thing to
yeah.
do. And then when we get older, we don't question these thought processes anymore. And now we're
Mm,
just living our whole life through, this was just one example, but we're
yeah.
just living our life in those ways. So that's what we do in therapy is what I was talking about right now is cognitive behavior therapy. So what
Mm,
we do is we look at certain patterns of cognition, like, especially CBT was developed around depression by Beck, right? So he
mm.
spoke about this negative triad of I am useless, worthless, I am bad, the world is bad, and the future is bad. Everything is bad, So he called it the negative triad of depression.
Mm,
So what we did was and then we find different patterns that people use, oh, my child has not called. What if something terrible has happened? What if they've met with an accident? So that's like a catastrophization. Or I'm
mm,
worthless, worst
mm,
person. So that's like a labeling. We
mm,
spoke about all or nothing earlier. So, these
mm,
are some of the patterns. So we help the client identify the pattern and then we help them dispute it and then
mm,
replace with like healthier ways of processing that trigger and eventually changing the way they kind of see themselves. So that is CBT, but something that's very helpful for the menopause transition is mindfulness based CBT also, because that helps with the mood swings. So being able to label your mood, recognize your mood, being able to identify triggers to that kind of mood, and being able
mm.
up with different ways of responding to what is coming automatically. So that's very helpful with the mood swings during the menopause transition. And along with that, interpersonal therapy is also very helpful at that time because being able to cope better with the changing relationships in your life is helpful. So these are some, and CBT actually we'll see a lot more studies on CBT because it lends itself better to research because it's a short form therapy with like
Yeah.
fixed, measurement criteria, but it has robust findings in depression itself. So that's one of the therapies that has
Mm.
been approved.
And CBT or cognitive behavioral therapy, for those who didn't catch
Yeah,
it, is
yeah,
also there's enough research now to basically CBT targeted towards hot flashes and vasomotor symptoms. There's robust
and
evidence suggesting
yeah,
that
yeah,
it helps women deal with it. Doesn't
yeah,
reduce the hot flashes, but definitely
yeah,
helps them deal better with the hot flashes.
yeah, yes,
And
yes,
going back to what you said at the beginning of the episode, that um, changing our or in the middle of the episode was
yeah.
basically looking at uh,
Imaging, yeah,
yes,
yeah,
yes, and
yeah,
it's instead of looking at the wisdom that comes with it, we want to be, if we continue to want to be the Supreet who was, as
yes,
opposed to the woman who is,
yes,
it creates
and
misery.
yes, and the woman who can be because you
Exactly.
know our life
Yeah,
expectancy has increased so much, so we
yeah.
have like average, at least I think you might know this better than me, at least 20 more years post menopause now that we have
At least. No, I'm counting
and
another 50, but
yeah.
but
So just the ability to, because of the freedoms that have come,
yeah,
because of your role changes, be
yeah,
able to take on so many more things in life, and not being able to see that is really it
yeah.
really takes away from an important part of your life.
Yeah, and I think part of it is also, like as you said, not being needed in roles that involve your children, your family. Your roles become for let's look at a typical woman at 50 whose kids have gone off to university or don't need her
Yeah,
anymore. Parents are no more, maybe. And so now
yeah,
suddenly it's like this vacuum. Oh my God, I have nothing. It's only me now. And
yes.
instead of saying I'm not needed, to use that time to nurture yourself.
Yes, invest back, that's
Yeah.
one of the things that it's a real luxury, so to be able to just invest that time in you and being able to use that.
Yeah, it's so
Yes.
beautiful. It's so
Yes.
beautiful. To a woman who's feeling overwhelmed and going through perimenopause and menopause or menopause. Okay, now I'm going to redo this. Okay. Since we are redoing, we might as well
Yes.
redo.
Yeah.
Okay. So, to a woman who is feeling overwhelmed at perimenopause or after menopause and is not sure if she needs help with depression, when should she seek help? What are the signs that she should look out for and say, hey, now I need to seek help?
Okay. So what I would suggest is if your mood swings, okay, so we're first talking about depressive symptoms. I'll talk about depression in a bit. So if your depressive symptoms, that is the irritability, the overwhelm and the crying, the tearfulness, right? If you feel that it's beginning to affect your ability to function, it's not clinical depression yet, but you're finding that it's affecting your interpersonal relationships, it's affecting your ability to maintain your social supports. Because if you're behaving like that, you might lose your social supports,
Mm,
that, or at least you're scared, you might, so if
mm,
it's affecting relationships, if it is affecting your ability to do pro health
mm,
behaviors, it's
mm,
helpful to at least start the going, perhaps considering therapy, perhaps considering, even some mindfulness modules, if nothing else, if therapy is not available to you,
mm,
right? But if it is, if you feel like your sleep is disrupted,
mm,
your energy, you're just finding that your energy is low for weeks and months on end, right? And
mm,
this, I think, like just that worthlessness and guilt as a ever present thought. I think that
mm,
is hallmark of depression, and I think that it's one thing to be like, oh, I'm so stupid, I did this dumb thing. But this whole thing every day, like, oh my God, I'm so bad. I'm so bad. It seems like just a small change, but most of my clients who've been depressed know that this is not sadness. It's an actually different condition, right? So a lot of times when it is accompanied like your vegetative symptoms, so your sleep, energy, your appetite suddenly completely gone or increased massively, along with this guilt, along with this pessimism, that's when you should go. You shouldn't wait till it reaches like, oh my God, all hope is lost. There's no point living anymore. Don't wait till then. When
mm.
it's mild depression, you're more likely to get away with a lower dose of treatment, sometimes get away with just psychotherapy. So it's better to go in early. Early diagnosis for depression is extremely, extremely important. So when you find that, then go in. Of course, when it gets darker than that, please definitely know this is an imminently treatable condition. It is very, very treatable with very, very non-toxic medication. So don't be scared of the treatment. Just go for treatment. You will get better. That's
Yeah.
that's what I always like try to tell my clients, like, just give me a month, please.
Just
Before you do anything,
do
just
it.
give me a month. Just trust me for
Just,
1 month. I'll see you to the end of it. Yeah.
yeah, yeah.
Yeah.
You mentioned at the beginning of the episode 5% increase in weight over a month. Is there
Or
also criteria
reduction.
for weight loss? Is it
Yes, 5%
so
change.
a
Change.
change?
Yeah.
Change. Okay, okay.
Change. Yeah.
Thanks for clarifying.
So most
And
likely a normal, like usually what we see in depression is weight loss,
mm,
but some people we see weight gain. Similarly, like usually in depression, we see the inability to sleep. So
mm,
loss of sleep. But for some people, we might also see like sleeping all day long. So
mm.
we call that like an atypical depression, but that's both of them are common. Yeah.
Um, Also, you mentioned the use of antidepressants, and I just wanted to kind of go back to that, just because there's this if someone has to decide between antidepressants and hormone therapy, just a hypothetical situation, I just want to use this, and I keep using this, using any excuse to kind of push this, slide this in, is that there could be symptomatic treatment and then there could be overall treatment. And as you said, hormone
Yes.
therapy may improve your mood, but it will also help your
Improve.
bones and probably
Yeah.
your heart and your
Heart
cognition and many
and your
other
cognition.
things.
Yes.
Yeah,
Yes.
yeah.
Yes. Absolutely.
So
So,
it's a
so
more
that
kind
would
of,
be, yes. If and we know that this depression is more to do with a menopausal transition, I would 100% recommend first, please get hormone therapy. There is this it's a slightly controversial thing. I think you and I had spoken about it briefly before, especially if the person doesn't have a pre-existent mood disorder, right? So we've not had depressive episodes ever in the past. And you can almost kind of say with a lot of certainty that this depression has more to do with the menopause transition than an actual pre-existing mood disorder. I would definitely recommend hormone therapy because of its holisticness, being able to treat everything, and then it would preclude, like, the need to take antidepressants, because that is like, it's kind of like treating the root cause rather than just, as you said,
right,
symptomatic.
right.
Yes.
Okay, so coming to the end of the episode, starting on, ending on a positive note, can you give us, our listeners, these are women who are probably in their perimenopause and menopause, facing sadness or depression, 3 pieces of advice about how to get through this?
Okay. So my first advice would be that early diagnosis of depressive symptoms and depression itself is paramount. Very, very important. It is something that would help you also instill pro health changes in your life. So getting that treated is very important. The second thing is that being able to seek social support and attitudes, as we discussed, is extremely important. And the third thing is understanding how treatable depression is. Depression is very, very treatable. It is one of the disorders that is put in the common mental illnesses category. So even if you don't have a psychiatrist where you stay, most physicians, including your family practitioners, can treat the depression, right? So please do not wait, especially in certain countries where it takes very, very long to get a psychiatric appointment. Please go to any health practitioner, especially because hormone therapy itself is the best treatment for depression related to menopause. Please go to any health practitioner. You don't have to just make it to a psychiatrist.
Right.
So those are the
Right.
3 things that I would
Well,
definitely.
pearls of wisdom. Thank you so much for sharing them. And this has been an interesting, super interesting conversation. Actually, I can go on for another couple of
Yes,
hours with you, but
yes,
perhaps some
yes.
other time. But
Thank you
thank
so
you
much,
so
Dr.
much for sharing this wealth of information. It, I'm sure everyone's going to benefit from what you had to say today. Thank you so
Thank you
much.
so much. Thank you so much, Dr. Sukhpreet. It
Bye bye.
was lovely being here.
Thanks.
Thank you. Bye.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.